Good morning, everyone. Can you guys hear me?
Yes.
I see people are trickling in. A minute or so before getting started. Okay, we'll go ahead and get started. Do want to be mindful of time. Good morning, everyone. My name is Jessica Camacho Hall. I am the section chief for the Justice Involved Reentry Services, and I will be facilitating this morning's call. I want to give all of you a warm welcome to the Health Services Justice Involved Reentry Initiative. Before we get started, I did want to take a few minutes to introduce to all of you our new interim deputy director, Bambi Cisneros, who is on here. I don't know, Bambi, if you want to say a quick hello.
Thank you, Jessica. Yes, I'm on. Hello, everyone. Good morning. As Jessica mentioned, my name is Bambi Cisneros, and I'm the Interim Deputy Director for Office of Strategic Partnerships. And I am looking forward to leaning in to see how we can best support you all in this implementation. So thank you again, team, for staffing this call, and looking forward to learning and hearing from you all. Thank you.
Bambi. So we'll go ahead and go on to our next slide. I am going to be going over some of our housekeeping rules. So as a friendly reminder, please use either a computer or phone for audio connection. Please mute your line when not speaking. Participants are encouraged to submit questions through the Q&A feature throughout the presentation. And for any questions or comments that you might have that may not necessarily be answered during this call, or questions in general regarding the initiative, you guys can email the CalAIM Justice Advisory Group at dhcs.ca.gov inbox. So we'll go ahead and go on to the next slide. So during this call, we are going to provide a May recap for all of you on what was discussed during that all-county call. We are going to have a Medi Cal Rx overview for pharmacy GI pre-release services that our Pharmacy Benefits Division will be presenting on. We'll also have a presentation from our CAMIS team in conjunction with our Gainwell partners. That's going to be on the overview for Medi Cal GI pre-release services. We'll have some Q&A, provide some DHCS updates, and do the closing remarks. Can we go on to the next slide, please? So now I'm going to go over into the all-county webinar recap. And for those of you that are just joining, welcome. I'm going over recap for May. So during the call, we provided an overview of the key causes for delays or issues with our provider application and validation for enrollment, also known as PAVE. In that presentation, we shared some common mistakes that our provider enrollment division has noticed, as well as outlined best practices that can be used to ensure that our applications, get successfully completed and processed. We also provided an overview of the Medi Cal requirements for the pharmacies that are part of the Justice Involved Reentry Initiative and are providing services to our Justice Involved population. We shared with all of you some important dates to remember regarding our readiness assessments. And then we also provided an update on our timeliness submissions. Can we go on to the next? So the focus of this presentation is, again, trying to provide regarding billing, differences between our pharmacy or versus Medi Cal claims. So we have on here our first presenter, who is Alice Kinting on behalf of our CAMIS team. So I'll go ahead, Alice, and pass on the mic to you.
Thank you, Jessica, and good morning. Yes, hi, I'm Alice Quinton. I am a manager with the CAMIS division. And we had heard that there was some confusion about what claims should be billed to which entity, whether it's Medi Cal Rx or Medi Cal fee-for-service. The hope here is that we can clear up some of that confusion. Next slide, please. And again. So we're going to hopefully I help you identify which claims are billed to which entity. Next slide. So Gainwell, so we have two different fiscal intermediaries. DHCS itself does not process claims. We contract with Gainwell Technologies LLC, usually just referred to as Gainwell, and for medical claims processing under the Medi Cal program, and Prime Therapeutics State Government Solutions LLC, also known as Prime, for pharmacy claims processing under the Medi Cal Rx or MedRx program. In healthcare, for those who are not familiar with the term fiscal intermediary, an FI is a private company or other type of business entity that contracts with the U.S. government to process claims for for programs like Medicare or Medicaid. Go ahead. Medi Cal and Gainwell processes claims for medical services, including but not limited to physician services, surgeries, and most durable medical equipment. Gainwell does not process pharmacy claims. MedRx or Prime processes claims for pharmacy services, including but not limited to, as shown here, outpatient drugs, enteral nutrition products, medical supplies, and other. What makes confuse some of our JI partners is that MedRx does not include pharmacy services billed as a medical professional or institutional claim. Lists of covered services are available on the respective program websites as shown below. And yes, this deck will be shared, so you'll have the links. So here's just a few examples showing what is billed to which company. For an office visit for a muscle strain, the office visit is billed to Medi Cal or Gainwell. The ibuprofen that's prescribed by the physician is billed to Medi Cal Rx or Prime. Likewise, physical therapy for a knee injury, the visit is billed to Medi Cal. The lidocaine patches that may be prescribed for residual pain, Medi Cal Rx or Prime. Antiseptic bandages used in emergency room treatment. This is where it gets a little convoluted. If it's in the emergency room, it's Medi Cal or Gainwell. But if it's prescribed for use post-emergency, it's Medi Cal Rx or Prime. Now, note that the one constant in all of these is the word prescribed. If the thing is prescribed by a medical professional, it's billed to MedRx. And again, full lists of billable items are available on each program's website. And if you feel you're still confused, please reach out to our call centers. Medi Cal is 800-541-5555. And they're open 8 a.m. to 5 p.m. Monday through Friday, except for holidays. For MedRx, it's 800-977-2273, and they're open 24 hours a day, 7 days a week, 365 days a year. Hopefully that helped clear a few things up, and I'm sure you'll still be confused. So please reach out to our call centers. Thanks. Jessica, back to you.
Thank you, Alice, for your overview. We are now going to be having Katie Campora present on behalf of the Pharmacy Benefits Division on Medi Cal Rx JI services. Katie, the floor is yours.
All right. All right. Thank you and welcome, everyone. Next slide, please. Okay. Again, just like Alice said, we want to share whatever we can do to help make every claim submission successful. And so the goal, of course, is always to reduce the denials, the rejects, and the reversals by improving the accuracy that starts on the front end. And so we will go through some of the basics of claim processing, all the components of the claim, things like prior authorizations, and also share some key resources for all of you that hopefully will help make your claim process smoother. The next slide, please. All right, and the next one. We'll go through the basics of a pharmacy claim submission. So as you all are probably well aware, there are different ways that you can get that claim submitted to us. The probably the most common one are the point of sale. That's the little terminal. There's web and batch, and there are also paper and fax claims using a universal claim form and some different pharmacy claim forms. Next slide, please. One of the most important things about your claim submission is that you want it to be accurate and you want it to be timely, because unfortunately, when the claims are not timely, you will eventually run into reduced payments, and certainly don't want that to happen. And so it's always important to get those claims issues resolved just as soon as possible so that you don't run into the 6-month billing limits and those claim cutbacks. Next slide, please. Another important part of the claim submission and a successful claim submission is the PA request process. And so there are different ways that you can submit those prior authorizations to us. You can use your POS system doing the NCPDP P4 transaction. You can go into the Medi Cal Rx secure provider portal. You can use Cover My Meds. You can fax those to us, and you can also mail those to us. And when you receive this presentation, there are links that explain the details of each of these, and also on our resource page. Next slide, please. And essentially the basics of that prior authorization process are, it's submitted to us, it's reviewed, and then a decision is made. It's either approved, it's modified, it's deferred, or it's denied, in which case you may need to provide additional information back to the reviewer to get that approved. Next slide, please. And the next slide. So when we were doing some claims analysis for data service in April, we had about a 30% denial rate. And from that, 29% were reversed and then paid upon resubmission. So they were close. A lot of mismatches on the member eligibility or in their IEDs were mismatched. The drug utilization review or the DUR conflicts, missing diagnosis data, which is very important, or a product that wasn't covered or discontinued NDC code was used, or a prior authorization was not submitted. Also missing or invalid NCPDP fields on those claims. Next slide, please. And the next slide. So essentially, to get that claim to pay, the member has to be enrolled in Medi Cal, of course. They've got to be JI eligible for the data service that is on that claim. Also need the NPI number of the prescriber meets the Medi Cal ordering, referring, and prescribing enrollment criteria, and that claim submission method, whether you're using point of service, or the website, FTP, that all of that is correctly configured. And we do have a slide that shows all of the codes that you'll need to make sure that you are correctly configured for that payer sheet. So the key actions from this is to validate the eligibility before dispensing, so you don't have a rejected claim. Verify the member ID, check the spelling, and check the format to be sure it's correct, and be sure that the service date falls within their JI enrollment window. Next slide, please. And the drug utilization review. So DUR, you'll hear lots about this. So some of our most common reasons for denial are age restrictions, early refill, like a refill too soon logic is coming up. and also drug-to-drug therapy conflicts, or the diagnosis is not meeting the utilization management criteria. So to correct this, of course, use your diagnosis codes when they're required. Use the submission clarification codes, the SCCs when allowed. And if the DUR reflects a utilization management requirement, submit that prior authorization request. And this will help you avoid multiple resubmissions without clinical correction. So you always want to make sure that when you do resubmit, make sure you're making those appropriate corrections on the claim. Next slide, please. All right, our diagnosis codes. So many of the code 1 medications may require a diagnosis code. When it's required, the missing or invalid diagnosis codes are going to trigger the reject 80 error code. An example of this could be a labeler restriction, like a specific manufacturer's required, age restrictions, depending on the age of the member, certain diagnoses may be tied to certain diagnoses, and the claims will need to include the appropriate ICD-10 code on there. And do remember that DHCS is preparing for an expansion of the diagnosis code requirements to all pharmacy claims. So the sooner you're able to adopt these good practices will help improve your overall claim success rate and prevent those unnecessary denials. So just remember to confirm your ICD-10 codes. The diagnosis is on the claim when it's required. Ensure your system is configured to support reported diagnosis codes on each claim. And gently educate your prescribers that every prescription should include a diagnosis code, and that will help make your claim submission process much smoother. Next slide, please. A lot of time we see the denials are resulting from the product or service isn't covered. It's a discontinued product or discontinued service ID number. And the best way is to always check the CDL, the Medi Cal Rx contract drugs list. And there is a link to that if you don't have it at the end of this slide deck. Refer to the Medi Cal Rx approved NDC list and switch to that NDC when needed, and submit those PA requests for coverage restricted drugs. And that will, again, help ensure a smoother claims process. Next slide, please. All right, your prior authorization requests, more paperwork for you. So those PA requests are generally required due to age requirements, diagnosis-based criteria, the quantity limits, or if a drug is a specialty drug or is subject to step therapy rules. So submit your PA requests when required and include medical justification, a diagnosis, relevant labs, prior therapy, prescriber notes. All that information helps for a decision that will be made in your favor. And of course, ensure that prescriber is enrolled. This is an ORP requirement for claim submission. Next slide, please. Okay, and on your NCPDP fields, frequently we are seeing invalid fields or missing fields for the NPI number of the prescriber or the provider, the product or service ID qualifier, the quantity prescribed, a diagnosis code, there's another payer reject code, or unit of measure issues. And so just within your POS or your EHR systems, just be sure that those mandatory fields are enforced before submitting those claims to us. Next slide, please. This is your checklist for clean claim submission. So of course, confirm your member ID and their eligibility for that data service. Make sure all those align. Verify the covered NDC and the contract drug list inclusion. Check to see if there are any prior authorization requirements for the medication. Add that diagnosis code as required. Apply the SCC code when appropriate, and complete all the NCPDP fields to avoid missing or invalid errors, and proactively resolve those DUR conflicts. Next slide, please. Okay, this is a little matrix that we use to give you just a really high-level look at some of the most common issues that we see and how you can correct those. And And again, just more resources for you, a little checklist as you are submitting those claims to be sure that everything is covered and that you will have a successful claim submission and payment. Next slide, please. Okay, now we have a couple of pages of resources for you. Take a look, of course, at the Medi Cal Rx website, the contract drugs list, which is updated monthly, the approved NDC list, and then the billing tips and payer sheet has some useful information for setting up your payment structure. Next slide. Some of our other resources that will help you understand the difference of pharmacy claims, successful claim submission, our checklist. And of course, if you do have pharmacy questions, please send them to us at the Medi Cal Pharmacy Benefits inbox, and we are happy to provide assistance to you. Thank you.
Thank you, Katie, for that overview. We are now going to be passing it on to Cassandra Veramontes on behalf of our Gainwell partners. She will be providing some information to all of you regarding our Medi Cal fee-for-service billing.
Thank you, Jessica. All right, good morning, everyone. So we're going to go over some of the Medi Cal fee-for-service billing items. If we can go to the next slide, please. All right, so some of those key objectives that we will be reviewing is straightening your claims accuracy to reduce errors and reprocessing, review 6 months of data in relation to some RAD denial trends that we have identified, and provide you with some guidance and resources to strengthen your billing confidence and minimize those denials. Next slide, please. All right, so what we did is we looked over the past 6 months in relation to the submissions received for JI billing. Some top identified RAD codes have been RAD code 10, the service is a duplicate of a previous paid claim, RAD code 394 for the treatment period from through billing, RAD code 392 for the rendering provider number, and then RAD code 82, the service exceeds the maximum allowable. Next slide, please. So we're going to break those down a little bit to provide you guys with some more information in relation to each of those top 4 identified denial trends. The first one is RAD code 10, which is that duplicate of a previously paid. We are typically seeing this occur when providers are billing for bundle 2 care coordination. Again, the billing frequency for that is up to 8 times per week per member. We are seeing where providers are billing more than 1 unit for the same members, same date, same physician. We could go to the next slide, please. So again, the trigger, identical services being billed for the same date of service. These are considered duplicate billing. So our suggestion is to follow our identical services billed guidelines, which is adding remarks in the remarks field box on the UB04, which is box 80. You can also attach an attachment to your claim to justify the reasoning for the multiple identical services being billed for the member. And again, just a reminder, a simple statement that the service is not a duplicate is not sufficient. Documenting, oh, that's a word. Documentation must clearly explain why the service was repeated and, if applicable, any additional information about the services being performed at those times. Next slide, please. All right. This one is a very popular one across a lot of providers, which is RAD code 392. The provider is not found. Some of the common billing errors related to this RAD code is eligibility, so missing or inactive JI aid codes. So please ensure that you are running eligibility and ensuring that the member has an active JI aid code if you are billing for those pre-release services. Again, those JI aid codes are the I2, 3, 4, 5, and 6. Another error that we're seeing is the incorrect type of bill. So please ensure that you're checking the type of bill along with the appropriate revenue codes. And then moving down, the applicable modifiers, ensuring that you are using the U8 modifier for those pre-release services. Again, bundles 1 through 4 should be billed with the U8 modifier. Bundle 5 is the exception. Bundle 5 should be billed with the XE modifier. Bundle 5 does not require the utilization of the U8 because Bundle 5 is a post-release code. I just wanted to highlight one more thing in relation to this code. 392 is also being seen across a lot of providers in relation to behavioral health codes and behavioral health diagnosis being billed on a claim. So we are aware of this issue and we are internally working to resolve that for you guys as well. So additional information in relation to this particular denial and behavioral health diagnosis being billed will be forthcoming. Next slide, please. The next one is RAD code 394, requires from through billing. This is prominently or predominantly seen when billing T2024, which is bundle 4. The billing frequency is that 1 time per member. Next slide, please. Next slide, please. Did it freeze or did I freeze? Oh, okay, thank you. All right, so for this one, there is a specific format that must be utilized to bill this particular bundle. So line 1 would be the date prior to the date of service. Line 2 would be your actual date of service, which would include that 1 unit and then the total charges. So we did provide an example of how that would look on a electronic claim, an EDI, and also if you were billing paper, how that would look on a paper claim. We do have instructions and there is a link embedded in this PowerPoint that you will have access to on from through billing format as well. There is a provider manual for that. Next slide, please. All right, the fourth popular RAD code that we're seeing is RAD code 82. The service exceeds the maximum allowable by Medi Cal. One example that I pulled was the 80307 drug test. We're seeing where we're getting claims for multiple instances of this. Again, this is a 1 service per member per data service. We have seen providers adding 5 units. Again, this is a 1 unit because it is 1 service per member per date of service. Next slide, please. So some additional information in relation to this one. Please ensure that you're aware of the frequencies for the codes that you are billing. Oh, sorry, I got distracted by a chat. Squirrel moment, I apologize. So for pathology specifically, if it is justifiable, you can obtain a treatment authorization request for the additional units. Once an approved TAR is obtained, you can submit your claim. Please ensure that that approved TAR number is on your claim should you need the additional units. And then we also supplied some information in relation to any appeals should your submission require the appeals completion as well. One thing I will say before we move on to the next slide about RAD code 82, not only is it seen on pathology codes, but I know that a lot of providers are also receiving this denial in relation to the H codes. A lot of providers have brought that to our attention where they're receiving this particular denial when they're billing the H codes. I know for short Doyle, there is specific billing rules when you're billing the short Doyle program, which are like 15-minute increments. So a lot of providers, when utilizing those H codes, are putting, 3, 4, 5 units. For fee-for-service Medi-Cal, it's just 1 unit. We're just paying, a rate for the 1 unit. It's not 15-minute increments like you're used to when you bill short Doyle. Again, when you bill fee for service, we're only expecting the 1 unit, and that's what we're paying on. It's not in 15-minute increments for us. Again, that's different when you're billing short Doyle compared to fee for service. So I just wanted to highlight that one as well. It wasn't added here. Next slide, please. All right, so justice involved inquiries can be submitted to our justice support team. Again, you can email us at our JI billing support at Gainwell Technologies mailbox. We do have a little short inquiry form that we do ask that you submit in relation to your inquiry. So again, you will email that JI billing support box. You'll get an auto response to instruct you to complete our inquiry form. And once we receive that inquiry form, we will respond with a case number for your tracking purposes and for our documentation purposes to document the interaction internally. And then you have something to reference should you want to follow up on status of your inquiry submission. And again, that's that JI billing support box. Next slide, please. Some valuable resources available to all providers, again, located on that Medi Cal website. You have the Justice Involved landing page where you can find the most relevant information or up-to-date information. We do post all articles related to JI on there, along with other additional reference material for you. The Justice Involved provider manual. We also have the billing tips for the RAD codes that we identify as frequent. Those are being updated and should be updated here in the next month with the most recent information. So please be on the lookout for that. We have the JI billing reference guide and then some other references that were other resources that were referenced today were also that pathology and the appeals completion. Next slide, please. I'm going to hand it over to Jessica. Thank you.
Thank you, Cassandra. So I want us to go through the Q&A questions going that were answered already. So friendly reminder, we are going to be sharing all of these materials as well as recording on our DHCS website, as well as emailing it all to participants that are registered during the call today. We did see that Alice provided the numbers for technical assistance. And then also if anyone wants to be added to our distribution list, to please email the CalAIM advisory group. And you see that Erica provided questions in the chat, and it looks like a lot of these questions might be potentially answered by Cassandra. I don't know if you're able to answer. How should the UB04 form be filled out for embedded providers?
All right, I do see quite a bit, Jessica. So the first one I'm going to start out with to address is the very last one that is not listed in 1 through 5, which is specific codes approved for dental billing for youth. So as of right now, dental billing for youth or adults is not a current policy for Gainwell. I know that there is forthcoming information from the department that is still under review, but at this time, there is no specific billing codes that are allowed at this particular moment for those dental services. However, I can say that it is forthcoming, and my DHCS partners can confirm or deny that, but I know that it is forthcoming for youth specifically.
Hi, this is Brian Hansen from DHCS. Can I just chime in on that real quick?
Of course.
Other folks on the DHCS team may know the actual current status of the ability to bill specific codes, but relative to the CAA federal legislation for requirements for reentry services for youth, there will be specific screening and diagnostic services that are available for youth. And that includes dental screening, vision screening, and hearing screening also. So we can follow up perhaps after this meeting with more specific code and status information, but for compliance with the CAA requirements, which are separate reentry requirements at the federal level, which have been rolled into our 1115 waiver process. The codes we're going to add a few codes specific to come into compliance with that. So they will be available as part of this whole process and billable. And again, unless anybody else has more specific information on the line about the status or details about those codes, I'm going to say we'll follow up after this meeting with more specific information.
Thank you, Brian and Cassandra. Would it be possible to get more clarification about the question that you put in the chat, Kimberly? And we can go ahead and unmute you just so that we can kind of get a little bit more understanding of what the ask is.
Yeah, and I'm sorry, just to add a couple more details. What Cassandra said is definitely generally correct. Dental services are not, strictly speaking, part of the benefit package for the reentry services that are reimbursed by DHCS. So what it is that we will have available are specific to dental screening services, and there's a couple specific codes I believe that we will have available for that now or at some point, specifically to come in line with the CAA requirement that we cover screening and diagnostic services for youth. Okay, I'm done. Thank you.
Brian, just to clarify, we did have someone say that Lisa Eddy was asking if to confirm that 0 dental visits for any adult inmates currently under JI, and just to reiterate, that's something that we are revising, but currently under CAA, it's particularly pertaining mostly to youth. Is that correct?
Yeah, I believe our current policy is that these services are for youth in alignment with the CAA requirements under federal law. There's a question about whether those dental services can be retro-billed. I'm going to add that question to our list of follow-up items. I don't want to go too far because I wasn't prepared for this specific question for this call. Yeah.
Definitely be following up on that. Wanted to go back real quick. Kimberly Danner, you had asked what category would an inmate fall into if they are incarcerated with no release date. I'm wondering if you could provide a little bit more context, and if we can unmute her so that we can get a little bit more description so that we can provide an answer.
Can you hear me?
Yes.
Okay. So we're providing behavioral health services in the jail, and we do that both for the entire time while the client is in the jail. So we're handling both pieces, not just the linkage piece, but also ongoing services in the jail. And so I'm kind of wondering what if we have I'm trying to understand the difference between reentry and pre-release and the linkage piece and make sure that we put things in the correct category. I think that the pre-release and the linkage piece go through the behavioral health system, the short dole behavioral health system, but I think the reentry piece is the one that goes through the MMIS system or to fee-for-service Medi-Cal. And I just kind of want to understand what is the so for the re-entry, so if we have an inmate that doesn't have a release date and it's unknown, that does that qualify as re-entry? And do we need to have a JI aid code in order to bill those services?
Jessica, do you want me to take a start? And
Yes, please,
I'm
Brian.
going to encourage other folks on the team because that was a fairly complicated question. So there may be things I don't get at. First, and the most important, for billing for any services to Medi-Cal that happen prior to release, the JI aid code will have to be in place on the date of service for that service. Generally speaking, the Division of Labor, I believe this is about, a county behavioral health organization or behavioral health claims in the pre-release period. Generally, and again, I'm going to ask folks to clarify if I don't get this exactly right. For regular behavioral health services that are provided while the JI aid code is turned on and during the reentry period, these would be regular clinical consultation behavioral health services. Those would be billed fee-for-service to CAMUS. What we are pointing towards for folks to bill through the short Doyle system is really only the behavioral health agency's portion of receiving a behavioral health linkage. So for the folks who are sending that behavioral health linkage on behalf of the correctional facility, their portion of that behavioral health linkage would be billed through CAMUS. The behavioral health agency getting on the phone, doing work related to receiving that behavioral health link prior to release as part of the mandated behavioral health links process would be billed to short Doyle. And again, we will follow up if there's anything that needs to be clarified about my answer on that. Okay, I'm going to stop there. Feel free to follow up if you have additional clarifying questions about that.
Thank you, Brian and Kimberly. You can send your questions to the CalAIM Advisory Group inbox if you need, additional follow-up on those questions or set up a meeting with us to dive deeper into this question. Cassandra, I see in the chat that you're providing additional questions. I don't know if you want to take the floor to address some of that.
Yeah, not a problem. So there was a question in relation to electronic funds transfers. So again, the correctional facility being the billing provider should be completing the EFT form in order to receive their funds for the claims that are being billed. So the EFT should be completed with the correctional facility's information. And then there was some claims completion information. So in relation to that, I already put it in the chat, we can schedule a meeting one-on-one to review claims completion with the provider. We also have a provider manual in relation to the UB04 completion outpatient services that one of my team members just dropped into the chat. So you would need to review the UB04 completion provider manual along with the Justice Involved provider manual, because the Justice Involved provider manual has specifics on what is required on the UB04 claim, like the type of bill, the revenue codes, modifiers that should be used. The UB04 completion just gives you an overall fee-for-service completion, and then the Justice Provider Manual gives you those details related to the program.
Thank you, Cassandra. Q&A. Oh, go ahead, Brian.
It's another clarification on dental. I saw a question about whether former foster youth up to age or under up to age 26 were allowed to were included in the eligible population for the CAA mandated youth services, and they are. So former foster youth up to 26 is part of the eligible population defined as youth under the CAA. So everything I said about the dental services, hearing, screening, vision screening also applies to former foster youth up to age 26. That's all.
Thank you. I do see here a couple of questions regarding prior authorization. Michelle de la Calle post, how do we seek PA if the JIA code is not on during the time frame the PA would be obtained? That's one of her questions, and I don't know, Katie, Erica, or some of our other pharmacy benefits division folks.
Yeah, I think.
Go ahead, Erica.
I'm sorry. I was going to say, I think Ivana, would you like to jump in on this one? Oh, it looks like Paul has his hand raised too.
You can unmute him.
Yeah. Paul, did you want to go? Unmuted. They are not unmuted. Ivana Thompson and on the win.
Okay, I think I corrected Paul's. Let me see if I can fix Ivana's. Okay, Ivana should be unmuted.
Thank you. I also see James's hand is up. Could we have a little clarification on that question? The PAs are tied to members' overall eligibility and their member ID. So they can continue past their JI eligibility after the release. I'm not sure how to answer the question. Could you please clarify?
Yeah, we'll have Michelle on mute since she's the one that asked the question. And Michelle, you should be able to unmute yourself.
Hi, can you hear me?
Yes, I can hear you.
So I tried to clarify it more on the second question. If you have somebody who comes in and we don't have the GI-8 code turned on because they're not 90-day pre-release, so they have a 150-day time frame. When we start the medication or we start the request for prosthetic, these are the two things that's come up. The billing time frame is at administration, right? So if the JIA code isn't turned on when you're starting the process, you have nowhere to take the prior authorization because they're not currently eligible. But at the time of administration, they may now be in their 90-day pre-release window and the JIA code is turned on. But we've already done all the work on the they're already receiving it, or we've already done the mold, we've done the legwork. Do we seek prior authorization when the 90-day aid code gets turned on, or they enter that period? Or how do we coordinate that in a way that we can get the reimbursement if it's at the time, if they're eligible at the time of administration or of handing
So-
off the item?
I was answering for the pharmacy PAs, but it sounds like your case is more of a medical or durable medical equipment
It
case.
could be
Yeah.
either.
Okay, so for the pharmacy PAs, like you mentioned, if they have no eligibility, then we can't really do anything. We can't find them anywhere in the system. So you can't really submit PA or a claim. And once a PA is approved, it would cover the eligibility period. At least that's what
So we could
that's
continue
how
that.
I understand it. And from CAMIS, if somebody can please jump in for the TARS, for the medical
Okay.
TARS. The difference being for the drug, you need to, you keep providing the drug, right? It's not one process that happened, prior to their eligibility. It's just you need to continue dispensing or delivering
Yeah.
the drug. And so you would be able to bill from during the eligibility period.
Can I just ask, this is Brian, a couple clarifying questions that I actually have. I have suspicions about this. The PA, can the PA be submitted? Like, let's say you turn on the JIA code on the 1st, you do a service on the 2nd, and then you submit the PA on the 3rd, and it's approved on the 6th. Does that work? Does kind of a retroactive PA work in this case, or do they have to be done in advance of the service date? One. So I'll let you answer that question first.
I can speak for the pharmacy PAs. That depends on how the PA is requested, and it just depends on the circumstances. Normally, we process PAs prior to service being rendered or medication dispensed. But there are certainly circumstances where we could apply it retroactively. And it just
Okay.
needs to be described in the prior authorization, in the chart notes, in the other justification.
Yeah, and then the second timing clarification, pretty clear that there may be nuances with what piece of work we're talking about and how it is billed and the timing. But generally speaking, if a piece of work that you're going to try to bill for is done prior to the JI aid code is turned on, if it's that piece of work that you're trying to bill for, it's not going to be eligible for claiming, unless it happened while during the time period when the JI aid code was turned on. Does that sound roughly right?
I'll tell you the experience we had that we couldn't figure out and we didn't bill for. And it was a prosthetic. So the prosthetic, you need prior authorization, but the billing occurs when you dispense it to the patient, right? So the dispensing of that item may occur in the 90-day period, but because the start of the project of the prosthetic creation occurs long before that, they weren't eligible during the pre-authorization period. So we couldn't get prior authorization to do something that wouldn't be billable until the prosthetic is delivered to the patient. So that's where it gets confusing when they're kind of in and out of that JI eligibility. So we haven't had it happen again, but for me, it's still this thing that's in the air where we want to be sure that we don't delay, or I mean, like we're not going to delay the start of that process, but it's potentially billable because it's falling in the period of time when the GIA code is active. So it gets a little bit funky there with this particular situation because they're potentially eligible because they're Medi Cal eligible. And anyway, I don't know how to better explain it, but it's complicated, I think. So it's just something that lives in my mind.
Thank you, Michelle. We'll definitely with you on this, preferably, via one of our one-on-one calls. I do want to be mindful of time. We have a couple more slides to go through. Did not answer all of the questions in the Q&A. Them during our for materials that will be distributed. So answering them and you will get those responses. So I'll go ahead and jump real quick to some updates and I'll let Adam present on those real quick for us.
Good morning, everyone. Thanks so much for your participation and engagement here as we kind of tackle these complex issues. Some updates before we jump into this readiness one that you see on the screen. A huge shout out to everyone who's submitted final progress reports for round 3 and round 4 of PAVE. We've had pretty much all but like 2 or 3 submit. So huge kudos. That was a great push. Everyone did a fantastic job getting that across the finish line. But now jumping into some readiness assessment stuff, we do have the October 1st deadline fast approaching. Hopefully everyone's tracking that. As a reminder, August 1st is the deadline to submit your readiness assessment. July 1st was our actual deadline. As of August 1st, 2026, if we do not have a completed readiness assessment on file for your county agency, you will be at risk of receiving a letter of non-compliance. Those we'll be looking at those in this coming week. So if that is your county, if you are worried about falling into that bucket, please do reach out to our CalAIM advisory group vanity email. Let us know the situation. We are happy to work with counties as much as we can. We really want to make sure that everyone's in compliance. Next slide. The next thing that we want to shout out to is the readiness assessment for counties without a correctional facility. I know this was in the works for a while, but we are tracking currently 18 counties that do not operate either a youth or an adult correctional facility that contract out part or all of their pre-release services. This survey has gone out already. It went out this morning. So if you think that your county should be in receipt of that and you are not, please contact us immediately so we can get that to you as soon as possible. We recognize that this survey came out later than the versions of the readiness assessment. So our deadline here isn't until August 31st, 2026. Please let us know if you have any questions related to those. That's all our major updates right now. So I'll pass the ball back to Jessica. And thanks again for all your engagement.
Thank you all for joining this meeting. As a reminder, any questions that we didn't get to, we will make sure to get to via our Q&A materials that we're going to be posting. The recording as well as the presentation slides will be shared with all of you via email as well as posted on our website. We thank you all for taking this. For real quick, for any remarks regarding the Smallville County, feel free to email us at our CalAIM advisory group at dhcs.ca.gov, either to confirm what emails we sent it to or clarifications. And all of you at our next meeting. And real quick, Adam, I see you have.
Yeah, I just saw a couple of questions kind of start popping up for that rural, the small counties readiness assessment about the different dates. So just want to reiterate, August 1st is the due date for the readiness assessment for counties who do operate their own correctional facility. August 31st is the deadline for counties who contract out part or all other pre-release services. Hopefully that clears that up.
Thank you. And again, if any questions come up, feel free to email us. And we look forward to meeting with all of you again at our next all-county call. Hope you'll have a good rest of your day.